Hello my dear students, I am Dr. Vaishaly Bharambe. I have been teaching anatomy for the last 25 years and I love it. Today I am starting my shoulder joint series. Okay, so in this I am going to cover shoulder joint, okay, under the following headings. So one lecture will contain name, classification, bones and ligaments, and another will contain relations, movements, muscles, blood supply and applied anatomy. Okay, so today's lecture is part 1. Part 2 is also uploaded. Kindly go and see the link in the description section and watch part 2 as well. Right. So let's begin the first lecture, shoulder joint 1, with the question, what is shoulder girdle? Okay, sit comfortably students. It's going to be a 15 to 20 minute class. I want you concentrating and comfortably. Okay, so tell me, what is shoulder girdle? See, your clavicle and your scapula, which help to suspend your upper limb, are referred to as the shoulder girdle. The shoulder joint is not a single joint. This is something which you may not find very easy to understand. It's not a single joint, it's a multiple joints. So the first joint, of course, is glenohumeral, between the humerus and the scapula, as we understand. But it also involves a sternoclavicular joint, a acromioclavicular joint, and a scapulothoracic linkage. So what does all this mean? It means that every time you can keep your hand on your chest wall or on your clavicle, do it, and then move your arm, move your glenohumeral joint. Did you feel your clavicle moving? Yes? So that means that when I say shoulder movement, it is not only my shoulder joint where the movement is taking place. There will be a parallel movement of the clavicle at the sternoclavicular and acromioclavicular joint, and there will be a movement of scapula at the scapulothoracic linkage. This is something you need to think. Okay, it will be wonderful if you are able to put this in your answers. Right. So today we are discussing glenohumeral part of shoulder joint. Right. So that's our lecture today. Before I begin, I have a small request for you. Can all of you sit with the scapula and humerus like I am sitting with the scapula and humerus of the right side. I have ensured that I have seen which side the bones are on. Every time I explain, if you have a scapular humerus of your own, it will be easy for you to understand the lecture. Right. So let's begin. First question, what is shoulder joint? Okay, it's a joint present which attaches the upper limb to the rest of the torso of the person. Does it have an alternative name? Yes, it does. It's also called as glenohumeral joint. How do I classify it? You will say, ma'am, I know it, don't bother. You do? So you will say, ma'am, it's a ball and socket type of joint. But ये तो तुम्हें standard 7th में आता था. For that you need not come to MBBS, right? How would you explain the classification as a medical student? You will. So I'll tell you how to do it. Does it have a joint cavity? Yes. So I will call it synovial joint. How many bones are participating? Humerus and scapula. 2. So I will call it a simple joint. What is the shape of the articulating surface? One is a socket, one is a ball. So it's a ball and socket type of joint. How many axes of movement do I see? 1, 2, multiple? Multiple. So it's a multi-axial type of joint. Now write down, after explaining all this, the classification of the joint is simple synovial multi-axial type of ball and socket joint. Is that clear? Simple synovial multi-axial ball and socket joint. Then you are answering as a medical student, not as a standard 7th student. Okay? Right. What are the bones participating in this joint? The bones are scapula and the humerus. Now let's describe them. Oh my God, ma'am, are we going to describe the whole bone? Why is it so? What is the necessity? It's not necessary at all. Just describe the parts which are relevant to the joint. I'll show you how to do that. So here you're seeing the scapula. The glenoid cavity is participating in the joint. So here's your glenoid cavity. Behind it you can see the spine of scapula. Okay. This spine will help to divide the dorsal surface of scapula into an upper and a lower region. Upper region giving origin to supraspinatus, lower region giving origin to infraspinatus. The acromion process here is overlapping over the glenoid, giving attachment to the middle fibers of deltoid muscle. The glenoid cavity is quite shallow, students, and on the costal surface, inferiorly there is a fossa below it which gives attachment to subscapularis muscle, and this blue border which you are seeing, okay, gives attachment to the serratus anterior. You must be wondering, ma'am, why are you telling us these all the details? I am telling you because see, now you have understood that over the glenoid cavity there is supraspinatus, behind it there is infraspinatus, in front of it there is subscapularis, and along its border there is serratus anterior. You learnt about muscles acting at the joint, isn't it? So whenever you are doing bones, do the ligaments a little bit, do the muscles, and prepare your mind for the joint. Continuing further, look at the scapula from the side. You can see that the cavity is somewhat pear-shaped, superiorly bound by a supraglenoid tubercle which gives origin to biceps brachii, long head. Inferiorly bound by the infraglenoid tubercle which gives attachment to the long head of triceps. Superiorly it is bound by acromion process here and the coracoid process here. Stretching between the two is a coracoacromial ligament. You can see it here. Okay. So the coracoid process here gives attachment to pectoralis minor medially and coracobrachialis and biceps brachii short head at the tip. We learnt a lot, students. We've learnt about coracoacromial ligament, we've learnt about pectoralis major, coracobrachialis and the short head of bicep muscle, a lot just by describing the bones. Right. So similarly, let's talk about the upper end of humerus which participates in the joint. Take the humerus now. Hold it correctly. Since it's a right side bone, I'm going to hold it in the right hand. Okay. Now let's take a look. First thing what I see is a rounded head which is 1/3 of a sphere. At any point of time, 1/3 of the humeral head comes in contact with the glenoid cavity like this. Okay. As you can see, as the head goes towards the rest of the bone, it shows a tiny little depression which is called the anatomical neck of humerus. If you go further and you suspend the bone in this manner, you come to the surgical neck of humerus where it is related to axillary nerve and posterior circumflex humeral artery. Okay, right. And now you can see a dotted line drawn here which is the attachment of the capsule. As you can see, the capsule is deficient for passage of a groove. This groove is called the bicipital groove. What is it called? It's called as the bicipital groove. Please feel it. Bound medially by lesser tubercle, laterally by greater tubercle. The lesser tubercle here gives attachment to subscapularis. The greater tubercle here gives attachment to supraspinatus muscle. Turn the bone around, the greater tubercle continues backwards to give attachment to supraspinatus, infraspinatus and the teres minor muscle on the posterior surface. So hold the humerus correctly, subscapularis, supraspinatus, infraspinatus, teres minor. 4 muscles attached to the upper end of the humerus. Come further downwards into the intertubercular sulcus. Laterally it gives attachment to pectoralis major, medially to teres major. And there is a groove in between where there is a lady between 2 majors. Who is the lady between 2 majors? Latissimus dorsi. Okay. Further down you see the attachment of deltoid and coracobrachialis. So these are all the attachments to the upper end of humerus. Let's move on to the ligaments of the joint. revise quickly what all. Think what all you learnt about deltoid and humerus, revise it and then come to ligaments. Ready? Right. So, things you should discuss under head ligaments would be articular cartilage, glenoid labrum, capsule, transverse humeral ligament, glenohumeral ligament, and many others. I won't read out all of those. Let's begin studying the ligament by talking about the first thing, which is common sense. If it's a synovial joint, it will be covered by articular cartilage, which is a kind of hyaline cartilage, such that the cartilage is thick in the center and thin at the periphery on the convex surface, which is the humerus, and thin in the center, thick at the periphery on the concave surface, which is the glenoid cavity. What does it do? It allows for eyes on eyes, frictionless movement between the two articulating surfaces. Easy? You can write the same for any joint in the human body. The articular cartilage on the glenoid cavity is having a extra additional cartilage around it, which is called the glenoid labrum. Let's take a look. So here's your glenoid cavity and here's your glenoid labrum, which is colored differently because it's a fibrocartilage. It is attached along the entire edge of glenoid cavity except superiorly, where there is a gap in it. What is there in the gap? Long head of bicep brachii getting attached to supraglenoid tubercle. Very important. What does glenoid labrum do? It deepens the glenoid fossa, which is very shallow, and thus helps to hold on to the humerus during the joint formation. Right. Sometimes this glenoid labrum may be damaged in the antero-inferior. Take a look. In the antero-inferior region, this is called as the Bankart's lesion. So now if there is a lesion here and the patient gets pushed from posteriorly, the humerus is unable to stay in the socket because anteriorly glenoid labrum is damaged. So when somebody pushes this from behind, the humerus promptly pops out and comes to lie. See? The humerus pops out and comes to lie below the coracoid process. This is called anterior dislocation of humerus, which is a recurrent kind of lesion. Okay, so the glenoid labrum helps to hold the humerus inside the glenoid cavity. The lesion is called Bankart's lesion. Let's talk about the fibrous capsule. Any synovial joint always has a fibrous capsule around it, holding the glenoid to the humerus, holding the two bones together. So it will have a humeral attachment, it will have a glenoid attachment. Right. So it's a loose capsule which is attached on the scapula, just beyond the glenoid labrum. Can you see that it's going beyond the glenoid labrum, such that it includes the origin of long head of bicep brachii in it. What is the significance of this? This is how your long head of bicep brachii becomes an intracapsular joint, intracapsular tendon. Laterally it's attached to the humerus. We've done this, we'll do it again. It's attached in this along this dotted line with two gaps in it, or two variations to be remembered. The first gap in the capsule is at the bicipital groove. Okay, it's at the bicipital groove, where through this gap your long head of bicep brachii emerges out. Another peculiarity of the capsule is along the medial surface of the humerus. It is not attached to anatomical neck of humerus, but it goes about 1 centimeter below. So on the medial side it is loose. How does it matter? I'll tell you later. So this is how you can see the intracapsular tendon of long head of bicep brachii emerging out, passing into the bicipital groove, held in place by the transverse humeral ligament. Why is it held in place? Because it might come out otherwise. So this here is your transverse humeral ligament, which acts as a retinaculum holding the biceps brachii down in place. Fibrous capsule also is supported by a number of muscles. It's a loose capsule. कोई तो इसको सहारा देना ज़रूरी है. Somebody has to help it. So from posteriorly there are pectoralis minor, infraspinatus, supraspinatus, subscapularis. Think, we've done this once. Teres minor, infraspinatus, supraspinatus and subscapularis. 4 muscles supporting it from all sides. These muscles are called as rotator cuff muscles. Okay, inferiorly it is related to long head of bicep brachial, triceps along with teres major. Okay, separated by axillary nerve and posterior circumflex humeral vessels. So what happens is the muscles on the top, the rotator cuff, are strong, whereas these long head and teres minor comparatively not able to support the joint well. This is why the humerus undergoes downward dislocation very easily. Take a look. If this is the normal abduction, if you suddenly abduct, the humerus tends to pop down. If you suddenly abduct, the humerus tends to pop down, causing downward dislocation of humerus during violent abduction. What happens when you're falling down and you're trying to hold on to something and suddenly your humerus is violently abducted, causing dislocation? Which structures will be damaged? Obviously, your axillary nerve and your posterior circumflex humeral vessels will be damaged. Another feature of capsule, it shows a gap anteriorly for the subscapular bursa. Take a look. This is the subscapular bursa lying beneath the subscapularis muscle. It's a bursa is formed by synovial membrane passing through the capsule to emerge out. Gap anteriorly for a subscapular bursa. Subscapular bursa can sometimes be inflamed, causing subscapular bursitis. Right. So what all did we learn? This is the most important ligament I will be describing to you, the fibrous capsule. You will talk about its medial attachment on the glenoid, including the long head of bicep, its lateral attachment on the humerus. In the lateral attachment, you have to talk about the superior gap for the long head of bicep, anterior gap for the subscapular bursa, inferiorly loose, and therefore there is an inferior dislocation and damage. Also, you have to talk about supports of the capsule in the form of 4 rotator cuff muscles. Now, can you tell me the muscles from posterior to anterior? Teres minor, infraspinatus, supraspinatus and subscapularis. Okay, when I was a student, I used to call it TISS, T-I-S-S. Teres minor, infraspinatus, supraspinatus and subscapularis. Right. So, question. Name the intracapsular tendon of shoulder joint. You will say, ma'am, obviously it is the long head of bicep. Then name the intracapsular tendon of knee joint. Answer it. Give me the answer in the comment section. Right. Students, if you are enjoying this lecture, do like and subscribe to my channel and do go on the website of our channel for solving MCQs. Correct. So let's talk about the ligaments now. We are done with these 4. We have a few left. Which ligaments? Glenohumeral ligaments. Glenohumeral. We'll go from glenoid to humerus. Fine. Coracohumeral. Coracoid to humerus. Fine. And then synovial membrane and some accessory ligaments. Let's talk about glenohumeral. Actually, glenohumeral are ligaments which are thickening or strengthening the capsule itself. Take a look. You have a superior glenohumeral, you have an inferior middle glenohumeral and a gap in between. Who passes through the gap? The subscapular bursa. Inferiorly, you have an inferior glenohumeral holding the glenoid to the humerus. All 3 are present anteriorly or inferiorly, not posteriorly. Superiorly, there is a coracohumeral ligament. Take a look. Okay. So, from the coracoid process to the humerus, supporting the joint from above. Okay. So, what happens? It resists excessive lateral rotation. Try to excessively lateral rotate, you will feel pressure here. Okay. It also prevents excessive adduction. So, glenohumeral 3, coracohumeral 1. Also present inside the joint is a synovial membrane. You know synovial membrane is present in every synovial joint. So also in this. The synovial membrane completely lines the joint at all places which are not lined by articular cartilage. Basic rule. Okay. It also extends out here, you can see, surrounding the biceps brachii as it emerges out of that little gap beneath the transverse humeral ligament. It also comes forward to form subscapular bursa. It might come out to form the infraspinatus bursa. You can see here how it is enclosing the bicep brachii tendon, and it is forming inside it is the synovial fluid of synovial cavity. Question: why does it form a synovial sheath? Can you tell me why it does so? Yes, it does so to provide a sheath for easy movement of the long head of bicep brachii. Since we are talking about synovial membrane, let's talk about the bursae also. So present here above the supraspinatus is a subacromial bursa. Very important. Okay, do not forget this. Separating the supraspinatus from the overlying acromial process. The same bursa can descend downwards in this gap, forming a subdeltoid bursa. There may be a bursa beneath infraspinatus called infraspinatus bursa. There is a bursa anteriorly beneath subscapularis called subscapular bursa. And finally, a synovial sheath. These are all the bursae related to shoulder joint. There are others as well, which I am not going to talk about because they are there and sometimes not there. What functions do they perform? There are so many muscles. They help to allow easy movement at the shoulder joint. No friction between muscles or between muscle and bone. Right. What is the applied importance? Ma'am, itna synovial bursa करे जा रही है. What is the use of it? One is that they can get inflamed, causing bursitis. Second is that sometimes they will be communicating with the joint. So, agar while doing surgery you open a bursa, you have actually opened the shoulder joint cavity, and that is important. So, this is the reason why we must know all the bursae at shoulder joint. Let's talk about the last 2 minutes of this class, accessory ligaments. Here you are seeing a ligament extending between coracoid process and the acromion, called as the coracoacromial ligament. Take a look from the side. This is the acromion process, this is the coracoid process, and extending between the two is the coracoacromial ligament. Together all of them form what is called coracoacromial arch. Now if you understand how this works, this arch, one second. This arch is present over the top. So anybody who is trying to push the humerus up is actually, this upward movement is prevented by the coracoacromial arch. Function is it protects the humeral head from above and it prevents upward dislocation of the shoulder joint. Got it? Right. So we've done the ligaments. Which ligaments did we do? Articular cartilage, glenoid, labrum and capsule, transverse humeral, glenohumeral, coracohumeral, synovial membrane and bursae, and accessory ligaments such as coracoacromial and coracoacromial arch. This is all what we've covered today. Okay, and so we are done with today's lecture, which is another name for the joint, classification of the joint, bones forming shoulder joint and ligaments at the shoulder joint. This is lecture 1. Our lecture 2 about relations, movements, muscles, bringing about movements, blood supply, nerve supply and applied anatomy is also uploaded under shoulder joint 2. I encourage all of you to attend this lecture as well to get a thorough knowledge of the shoulder joint. So students, if you enjoyed this lecture, do please subscribe to the channel, like the lecture and do share your thoughts in the comment section. So I enjoyed taking this class. I hope you enjoyed attending it too. See you across the screen, hopefully in shoulder joint 2 and also in other lectures. Bye.